Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. Today we're going to be joined by Dr. Michael Ott. Dr. Ott is a general surgeon here in London, and he is the chair of the Department of Oncology. Consider him to be kind of our local guru when it comes to anal and rectal diseases. So I'm really excited to bring him on to talk about what is often a number of topics that are misunderstood, admittedly by both patients and sometimes some physicians as well. Topics like hemorrhoids and anal fissures, rectal bleeding, lumps, when to see your doctor, that kind of thing. So Dr. Ott's going to tackle these topics with us today, and we'll be right back after this message. Welcome back. Again, we're pleased to be joined today by Dr. Michael Ott. Dr. Ott is a general surgeon here in London and the chair of the Department of Oncology at LHSC, and is going to be talking to us all about anal rectal disease today. So thanks again for joining us today, Dr. Ott.
Oh, thank you. I'm happy to be here.
And again, we spoke offline. One of the motivations I had for this talk is I find in family practice, this is an area where both patients and sometimes physicians have a bit of a knowledge deficit, where there's some misconceptions about things like hemorrhoids and fissures and how to best monitor things and when to see your doctor. So I thought it'd be a good idea to have a chat with who I consider to be probably our most esteemed expert in this area in town. So really happy to have you with us. So we'll start with rectal bleeding, kind of an easy one off the bat. When should patients be concerned about rectal bleeding? It's a question we get often, and patients sometimes neglecting it or not knowing kind of when should I see my doctor about this? When does it reach that level of concern? So what would you tell patients about when to be concerned about the rectal bleeding?
So I think there's a couple of things with regards to rectal bleeding without getting into too much nitty-gritty detail. The reality is any bleeding that's mixed with stool is important, because usually that's a sign of something more sinister, whether that be inflammatory disease, malignancy, or some other problem. If it's blood that's in the toilet paper or toilet bowl, it depends on the quantity and frequency. Usually we say something that is persistent or escalating is certainly something that should have some investigation. I think generally speaking, most bleeding should be mentioned to their family physician, but not all need to be investigated. And certainly if it's self-limited, or it's something that's just involved with cleaning after a bowel movement or something of that nature and kind of goes away on its own, there's probably no particular reason to be too worried. But things that are persistent or things that are escalating in nature, both quantity, frequency, or otherwise, are things that probably require some sort of discussion or evaluation.
And does age play a role in terms of when should someone be concerned or not concerned?
So my perspective is that age probably doesn't play a big role. I think if you look at, for example, some things that are sinister, if you look in the population, the average age or the group that has the highest incidence of colorectal cancer development now tends to be under the age of 50. I think a lot of physicians and sometimes patients feel that anything under the age of 50, you don't need to worry about it very much. Anything over 50, oh, we need to be scared about malignancy or cancer. That's not true anymore, and that paradigm's really shifted. So I think individuals that are younger still need to think about it, particularly if it's persistent, particularly if it's progressive, and particularly if it's mixed with the stool. And I think it's useful sometimes, again, for some of our colleagues to sometimes change their paradigm too, that recognize that we are seeing people with rectal or colorectal cancer in their 30s and 40s now, which is something that maybe a decade or two is pretty rare.
Certainly been reading in the literature kind of a demographic shift where more and more younger individuals being diagnosed with colorectal cancer. Has that been your experience as well locally?
Yeah, we're seeing a lot more frequency in people under the age of 50, and a bit more advanced cancer in younger people. It's hard to know whether that advanced nature is because of just delay in diagnosis, but it's not uncommon that many patients will say they weren't worried about it or didn't think about it as being something sinister, and sort of maybe put it off in talking to their family physician because they feel a bit embarrassed or uncomfortable about it.
Shift gears to pain. So pain around the anus, people will come in with complaints of pain to us, either acutely, like a new pain that's just come up, where they're sitting in the exam room, kind of on one cheek, or pain that's been going on for a while. What are some questions you ask patients when they present with anal pain?
So I think we think a lot about sort of when does the pain come, the nature of it, sharp, dull, aching. Is it associated with going to the washroom? Is it associated with activity? Is it something they've ever experienced before? Is there any associated other symptoms, bleeding, discharge, fever, and chills, for example? Because there's structural problems, there's inflammatory problems, there's infectious problems that can all cause that discomfort. So we try and use some of those questions to try and figure out, well, what could be the cause of it?
One of the things that we see in practice and in family practice would be an anal fissure as a source of anal pain. How do these patients normally present? What would a patient feel if they were having an anal fissure?
So it's a really
And what is it? And what is it?
So it's a really common problem. So I think, first of all, that as I said before, I think sometimes people have complaints or concerns about perianal region and they're embarrassed to talk to someone about it. And I would advocate to talk to your physicians about it. We're all human beings, and it's a pretty common problem. So a fissure is really a tear in the perianal skin, usually in the anal canal. It can be caused by both diarrhea or constipation, or it can be caused by other causes, but primarily diarrhea and constipation. It's really what I explain to my patients is like having a paper cut in the web space of your finger. It's a tear. And so every time you open your hand, that paper cut will open up again. It's the same thing with the anus. So you will end up having discomfort. We describe things as acute. So usually in the acute setting, either they've had a really hard bowel movement or some other cause, and they'll have what they describe as very sharp pain. Usually it's pretty classic, feels like passing glass or razor blades out their bottom. Often there's some blood associated with it. The pain usually will only last for a few minutes or after bowel movements, and that's kind of the acute phase. People can get chronic anal fissures, which last, usually we define that somewhere around 4 to 6 weeks, in which it just doesn't heal properly. So that tear or that cut never really heals. Usually that's related to problems with blood flow in the area, and it's a slightly different problem. Usually an acute anal fissure will resolve on its own with good bowel routine, soft stools, good amounts of water, not a lot of straining on the toilet. When it becomes a chronic issue, that's more an issue associated with blood supply around the fissure. And so we have to use techniques in order to improve the blood supply to promote healing.
Any feelings about like we see sometimes some topical preparations from physicians, so topical diltiazem or topical nitrates. Any feeling on those for treatment of an acute fissure?
Definitely the first stage. So I would say the first thing is just a discussion about bowel habits. So not spending a lot of time on the toilet, good amount of water, which is not something we do very well in North America.
Mhm.
Trying to balance your caffeinated beverages with water, a reasonable amounts of fiber. But the first line of treatment beyond those conservative measures is topical ointments. We usually recommend that. We often use diltiazem, which is a calcium channel blocker. It relaxes the smooth muscles and promotes vasodilatation, so improves blood flow to the area. Nitrates can do the same thing, but my experience has been that most patients don't tolerate that very well. Nitrates are absorbed much quicker and people get headaches associated with them and therefore tend not to want to use the material. The diltiazem is pretty much the go-to to start with. Sometimes people will self-treat. I think it's important to understand that they'll use some over-the-counter products, often with things that will say preparation H or proctosyl HC. That's hydrocortisone is the HC part. And I think it's important to understand that sometimes the hydrocortisone, while it will soothe the symptoms, will sometimes impair the healing. So I think it's important if people have the symptoms, they think they have a fissure, to seek out medical care. And diltiazem would be my go-to to start. Yes.
Do you usually have them use a diltiazem as long as they're having symptoms, or a bit beyond that to prevent recurrence, or how do you and frequency in terms of how often during the day to be using the diltiazem?
Yeah, so we tell patients they need to use it religiously. We tend to describe using it 3 times a day. Often I will tell patients in the morning after their shower, at night before they go to bed, and it's some other time that's convenient to during the day. It doesn't have to be exactly, every 8 hours or something of that nature. It's important just to put a small amount on the outside and it gets absorbed. It doesn't need to be a large amount. And people need to use it religiously. We usually ask people to use it 2 to 3 months sometimes. So even though the symptoms may resolve, you have to continue using it because otherwise when you stop the medication, the blood flow goes away, the relaxation goes away, and the tear can come back again. So usually we ask people to finish a full course, which is around the 2-month to sometimes 3-month mark. And then once that's done, we would stop the medication and see if the symptoms have resolved. If they have, that's great. If not, then we sometimes need to escalate.
While we're on the topic of pain, something we see in practice is when someone's having issues with diarrhea or some issues with kind of perineal care, they'll get almost like kind of a skin tear, kind of fairly superficially. So not necessarily a fissure, but some breakdown in skin there. Kind of guidance to give to patients who are experiencing that kind of symptom. So around the anus, some repeat irritation, and they're getting kind of sharp pains around the anus.
Yeah, I think that, I mean, realistically, the most important thing that I think in that scenario to try and keep the areas clean as possible, and then often to keep the areas dry as possible. So we tended to offer or want to use barrier creams. So barrier creams are different than creams that have steroid in them or other topical ways to treat symptoms. They're more actually a barrier to prevent material, liquid, water, other things getting on the skin and prevent any irritation. So that's probably the benefit. And then just really good perineal care as best you can. I mean, we often will tell people sometimes, particularly if they're having frequent diarrhea, using wipes as opposed to toilet paper. Sometimes it's easier on the skin. It's important if you're going to use wipes. Probably the cheapest and best thing to do is to buy baby wipes that have no fragrances associated with them, other chemicals. They tend to be the most milder. And then sometimes using a shower to wash the perianal skin as opposed to wiping with toilet paper, because depending on how frequently you're going, sometimes there can be abrasions just from even cleaning. So,
And we'll be right back after this message. Welcome back. Again, we're being joined today by Dr. Michael Ott. Dr. Ott is a local general surgeon and the chair of the Department of Oncology at LHSC. I'm going to switch gears to talk about hemorrhoids. So I find patients attribute anything around the anus to be a hemorrhoid, and so I think it's important to kind of clarify for them. So, in your own words, Dr. Ott, so what is a hemorrhoid?
So hemorrhoids are actually normal. They're a normal part of the anal anatomy. So we have cushions, if you will, in the anal skin that allow things to close and create that air, watertight opening that you want. Within those columns of tissue, I sometimes describe them as pleats and pants. There are veins, and those veins can become engorged. And so when they become engorged, the tissue around the anus that normally is there to keep things closed will swell. The internal side will swell and sometimes bleed, or sometimes even become thrombosed, which causes a lot of pain. And the external component will expand, and people can be left sometimes with some lumps or bumps in the perianal area, or even skin tags once the acute swelling is resolved. So I think it's important that everyone understands that hemorrhoids are a normal part of their anatomy. It's just when they become swollen or engorged, they then become problematic.
And what are some options for a patient with issues with, let's say, hemorrhoids that are visible, so they're a prolapsed hemorrhoid? What are some options for those patients?
So I think the key thing that patients need to understand is whether it's part of the external skin or whether it's part of the rectal mucosa. There's a dividing line there called the dentate line. Above that line, there's no sensation in the sense, so we can do a lot of things. So if it's prolapsing mucosa or prolapsing tissue, if it's small amounts, we can put bands on. Some individuals choose to do what's called sclerosis, which is injecting chemicals that cause those veins to shrivel up. I tend to find banding to be most appropriate. That's what I go to. And that prevents those tissue from prolapsing. It prevents them from falling out. It prevents them from bleeding. If it's external tissue, that's skin. So it's the same as if you had a skin tag or somewhere else on the body. You can't obviously deal with it that simply, but it's pretty simple fix in the clinic. We put a local anesthetic in. It's like being at the dentist. It's a little uncomfortable to put the anesthetic in, but then we can remove that excess skin or that excess tissue, and then the discomfort or irritation from that goes away. So it depends on where the hemorrhoid is located and which portion is causing the problem. But there's multiple things that are pretty easy fixes that improve people's quality of life. I found just anecdotally, lots of people will kind of suffer for years and years and years before they either approach their family physician or anyone else. And you fix that problem for them, and they're so thankful because it does interfere with their quality of life, and it's not a complicated fix for most people. Again, just that barrier to have that discussion of what's going on and get someone to take a look at it is really what's been in the way. So there's pretty simple things that are not very invasive that we can improve the quality of life of patients.
In your experience with hemorrhoid banding, symptoms that are largely leading patients to require the banding, are you finding it's bleeding primarily, or persistent discharge, or itching, or kind of just a mix?
I think the itching part is usually the outside. I think the biggest thing that banding is beneficial for is bleeding,
Okay.
prolapsing mucosal tissue. And then I think some people will be confused around what they will sometimes call incontinence, but is really the prolapsing of the mucosa. And just like the mucosa in your mouth creates saliva, the mucosa of your rectum and anus produces mucus. And so when that mucosa is prolapsing, there'll sometimes be some wetness or staining in people's undergarments, and they'll confuse that with incontinence. It's not really incontinence, but it's messy and they don't enjoy it. But so those are the three main things that banding will deal with. Stuff that's usually causing itching or irritation is usually related to the skin, which can't be dealt with by banding. It usually requires another intervention, either removing the skin tags or, as we talked before, proper perineal care.
some topical preparations that maybe people have been prescribed for, whether it's anisole or they got preparation H off the shelf. Any value to those? What should, because I find anecdotally patients will have it in their medicine cabinet and be self-treating before even kind of coming to our attention. What do you tell patients about those kind of the preparations?
Yeah, I mean, so those preparations have their place. I think it's important to understand that most of those medications aren't necessarily treating the underlying problem. They're masking the symptoms. So those are either anti-inflammatory medications or hydrocortisone, which decreases inflammation. And so that kind of masks the symptomatology, but it doesn't treat the underlying problem that may be causing it. I think the important thing to understand is that those things can treat symptoms and there's nothing wrong with using them. But if they're being used for extended periods of time, then that's probably something that you should rethink and have a discussion with your family doctor. They're not made to be used for extended periods of time. So when I say extended, I mean, this is something you might use for a few days or a few weeks, but beyond that, if you're still having symptoms and requiring on a regular basis, you should probably talk to your family doctor or see a surgeon. There's probably some simple fixes that can be dealt with without you having to continue to use those preparations.
Perfect. Anal lumps. So again, we talked a little bit about, what someone has in a kind of an external hemorrhoid. What are some other kind of causes of external lumps that people may, when they may feel a little lump around the bum? What are some things that that it might be, and when they should be asking their doc?
Yeah, so I think the most common thing we see is, as we talked about, hemorrhoids and skin tags. So skin tags are sometimes leftover bits of skin when the hemorrhoid column swells, and then the swelling goes away, and you're left with this excess skin. That's the most common thing. I mean, there's lots of other things that can cause problems. We do see HPV related, so human papillomavirus, warts. That doesn't mean that people have had anal receptive intercourse, or it means that they're promiscuous in any way. It's not related to that per se. But we can see warts that need to be treated, and they need to be kind of evaluated by your family doctor or someone else, because those may progress on to things like squamous cell cancer of the anus. So ignoring those lumps and bumps is not a good idea. We can see thrombosed hemorrhoids, which are clots that form in that hemorrhoid column and cause usually excruciating pain, and that's people often will present because it's so painful. So that's not something people ignore. Infections or abscesses can occur. Again, usually pretty painful, but can, or fistulas, which are openings from previous abscesses. We always worry about, as I said, things that are persistent or progressive. So lumps and bumps that are changing or growing or bleeding are probably things that need to be assessed, particularly if they're on the skin. And then things that are interfering with going to the washroom certainly should be seen.
Anal itching. So we talked about hemorrhoids and maybe, skin tags and maybe that effect on itching. I'm sure you see patients with kind of chronic itching around the anus that doesn't seem to be improving despite what they've tried, what their family doc has tried. From a specialist standpoint, what are you asking patients? What are you offering patients? What's available for that?
And so I think the first thing we do is take a pretty detailed history around things like, chemicals that they're using to wash themselves, soaps, detergents. You'd be surprised the number of individuals that have some sensitivities or dermatitis that's related to something that they're applying to the skin, whether it be creams, soaps, or detergents that they're using. And so we consider modifying those. I think a lot of the itching and discomfort is, again, partially from wetness or moistness, particularly this time of year. It's very hot. People are outside, activities, and you're sweating, and it's a place that will accumulate moisture. So trying to think about keeping things dry in the area, wicking away will help with that. We do make sure that there aren't some other significant diseases. You can develop things like psoriasis. You can develop things like infections in the perianal area. So sometimes if we're not sure, we will do biopsies of the skin just to make sure we're not missing something that's more treatable or sinister. And then I think just, really taking good care of using barrier creams and things of that nature to prevent irritation is important. Itching or pruritus is really a difficult problem to solve. And so we try and look at causes that might be irritating the skin and rule out all the things that we can before moving on to anything else. But it is a difficult problem, and it does cause people a lot of distress.
Talk about general anal care. One question I'll throw out there that some people may often ask is around bidets. So some people will have bidets that they use or have been told to use. Your general advice around bidets?
Yeah, I mean, I think they're probably decent if people can use them and feel comfortable with them. I know that when we do, for example, procedures in perianal area, we often ask people to use a shower head or get in the shower to clean as opposed to using tissue paper to wipe. So I think it certainly can help. I don't think it's necessary, but it certainly can help. And it's not harmful in any way, in my opinion.
We've got a few minutes left. Just want to touch on colorectal cancer screening, if we can, since so we've got a few minutes available. What should patients know in terms of current screening recommendations for colorectal cancer? What they should be asking their doctor about if they haven't had that conversation, and what changes might we be seeing in the near future with colorectal cancer screening?
So I think it's interesting there. If you look across various jurisdictions and provinces and countries, there's differences all around. So it can be sometimes confusing for patients. I think the important thing is for patients to decide based on their personal history and their family history whether they're what we call average risk or whether they're at higher risk than average. So when we think about average risk individuals, we think about starting screening usually at 50, although I will say in some jurisdictions, for example, in the United States, they've moved that down to 45 or 40. And the UK, they're also looking at moving it to 40. And I think in Ontario, it probably would make sense to move it to 40. The evidence, as you were talking about earlier, suggests an incidence. But as far as Cancer Care Ontario is concerned, we usually start screening at 50. From what's supported in Ontario currently is both FIT testing, which is the immunochemical testing for looking for blood in the stool, or a screening colonoscopy. So if we're doing FIT testing, that needs to be done more regularly than screening, but screening colonoscopy can be done, again, average risk every 10 years. FIT testing is every year to every 2 years. If people are in a higher risk category, I think the important thing from my perspective to understand is that the data around things like stool testing, FIT testing for blood, that is based on average risk. So if you have a personal history of colorectal cancer, personal history of polyposis or number of polyps, or a first degree family relative, people always ask, well, there's cancer in my family, but it really isn't put you at higher risk unless it's a brother, sister, mom or dad, or child. So something in a first degree relationship with you with colorectal cancer, that moves you into beyond average risk. And then in those individuals, we tend to use colonoscopy as a screening modality. And often we use the target of, if it's a cancer in a family member, we usually think about 10 years prior to the incidence of that cancer. There's a whole lot of other screening criteria for very discrete populations that have genetic diseases, but that's not the vast majority of individuals. So.
All right. Thanks, Dr. Ott, for all your helpful answers today. And again, thanks again for joining us.
Yeah, it was really great to talk to you, and hopefully this has helped some people.
Again, thanks to Dr. Michael Ott for joining us today and giving us all those helpful tips about anal and rectal disease. So just to touch on a few of the important topics that Dr. Ott covered today. Around the topic of hemorrhoids, again, if symptomatic hemorrhoids are bothering for a period of time, it's one where while tempting just to get the same topical prescription maybe that your family doctor has given you before and ask the pharmacist to get it renewed, like Dr. Ott said, there are actual surgical fixes for some of these things, and may warrant a referral for a consideration of whether there might be a fix that improves your quality of life. Also touched on general care around the anus. So kind of avoiding moisture, the importance of barrier creams. Again, and when he says barrier creams, even simple things like Vaseline would be considered a barrier cream to prevent debris and other fluids from getting in there. Anal lumps, not ignoring those. So if there's a persistent anal lump, not just overlooking it, making sure that you're getting that checked out to make sure that it is something benign and nothing to be concerned about. And then lastly, colorectal screening, which we touched on in the end, making sure that having a conversation with your physician about which modality would be most appropriate for you, either the FIT test, that's the poop test that you're mailed, that you complete to make sure there's no blood in the poop, or a colonoscopy for certain individuals who are higher risk. And until next time, stay healthy.